السلام عليكم. بسم الله الرحمن الرحيم. I am Dr. Muhammad Talat, Assistant Professor of Radiology at University. Today, inshallah, we have VIVA session number 7, Neuroradiology cases. And before starting, I would like to emphasize that I uploaded full emergency CT brain course, and also I uploaded before MRI of epilepsy, MR photography, and you will find also in our ERA, Easy Radiology Approach channel, you will find how to report and tips in reporting. Let's go to our cases today to save our time. Let's start by candidate 1, middle-aged patient complaining of headache. If you want to scroll, if you want me to scroll, okay, as you like.
Sir, I would like to scroll if you are happy with that.
Okay. Yeah.
Sir, I'm
okay,
requesting control.
Yes, okay, go on.
Okay. Yes. These are CT brain axial images of an adult male patient. I will take a moment to scroll. In this CT brain images, which is non-contrast study, I can appreciate that there is some slit-like third ventricle. The lateral ventricle, anterior horn are also slightly a bit compressed. I can appreciate that the extra axial CSF spaces look a bit effaced. There is effacement of sulci and gyri on both sides, more on the right side. And sir, can you please repeat
I think the cortical sulci is almost okay. We don't have any significant effacement regarding the cortical sulci. Even the gray-white matter interface, I think it is preserved. Do you agree?
Yes, sir, I agree.
Okay. I think you have almost no significant findings, but can you search for any hidden areas? Can you review?
Okay, I will try to look for review areas. There is some calcification in the pineal gland.
Yes.
There are some. Sir, these bifrontal convexities are showing some hyperdensities.
I think this is an artifact, beam hardening artifact. Besides the bone, besides the Calvarial bones.
Sir, I will try to go in till the lower section. In this, I haven't appreciated any significant abnormality. I would like to see any other imaging or MRI, or if contrast enhanced CT.
Yeah. Can you focus on this area, please?
On this area, there's hyperdensity in the right
Yes. Okay, that's good. Yes, you are right. Well done. Yes, well done. I think as you, yes. Here,
there's a
this is
defect
more
in
dense
the right, I see,
than the contralateral side. Okay, well done. What is this?
So next, I would advise MR angiography for this patient. I would also like to history of any acute trauma. As I'm going further down,
we don't have any.
It is a bit expanded on the right side. Yes, it is quite significantly
what is this
expanded.
Structure? And what is this structure? Is it arterial? Is it venous?
Sir, it is. I think. Is it in CCA?
Okay.
It might be. I will. No, I'm going upward. Sorry. So is it okay if you scroll? I will give up the remote. Sorry.
Okay. Can I please? This is the common carotid artery. Okay. And this is the bifurcation. This is the external and this is the internal carotid artery. So this is the internal carotid artery. And what is this? This is the internal jugular vein.
This is internal jugular vein. Okay.
Yeah, this is the internal jugular vein, and this is the internal carotid artery. Okay, if you go more, I think it will go to the sigmoid sinus.
Yes, this is hyperdense.
Yes, hyperdense. It appears hypertensive. So what's your suspicious?
So
What's your suspicious diagnosis?
I'm having suspicion. I'm thinking in the line of internal jugular vein thrombosis, which has extended to the superior.
So it looks like a cord sign or hyperdense sign along the internal jugular vein, and it is suspicious for internal venous acute thrombus. We did really the MRI study for the same patient. Do you have any abnormality here?
Yes, sir. In the region of right internal jugular vein, there is a loss of hypointense signal, which is the normal finding which should be seen. Instead, it is filled up with some heterogeneous signal intensity area.
Yes.
It is also swollen, and I would like to trace it further down. I would also like to take the history of any recent infection or intervention or pharyngitis.
Yes. So we have here loss of the normal signal void pattern of the internal jugular vein on the right side as compared to the left side, and it appears distended, so it is suspicious to be thrombosed. And also, if we go to the coronal, look for this area. It is very bulky. Okay, and this is the flare image, also appears very bulky. And we did MR venography, sorry. We did MR venography to check the dural venous sinuses. And I think now look for this part. This is a transverse sinus on the right side. And we have here abrupt occlusion of the internal jugular vein. It is not like the contralateral side. This is a contralateral side. The left side is non-dominant side, but the right side is a dominant one, and we have abrupt occlusion along the internal jugular vein. Okay, if you have something like this, what will you search for? We proved that we have acute thrombus along the internal jugular vein. What will we do?
So I would urgently communicate the findings to the, first I would like to search for any, what is the cause, any underlying cause, if it is not seen in the neck region. I would like to urgently communicate the findings to the neuroradiologist for thrombectomy.
Okay, very nice. I think also we should add that we need to search for any cause. Sometimes that we have severe otitis media, mastoiditis, and abscess formation, something complicated. Sometimes it is complicated by sigmoid sinus thrombosis. We don't have any infection in the middle ear or mastoid ear cells. Also, we should search for any complications, any venous infarction or hemorrhagic venous infarction. We don't have any hemorrhagic venous infarction. And as you said, we should inform the clinician as soon as possible to start the anticoagulant therapy. And really, we did for the patient follow-up after, I think, 3 months. And here, the internal jugular vein starts to be recanalized and starts to restore its normal caliber. Okay. Thank you so much, candidate number 1. Thank you. Well done. Because it is one of the difficult and the challenging cases, really. Okay. Candidate number 2. Trauma case. If you want to scroll.
Yes, I want to, sir.
Yeah.
I'll request control.
Yes, go on.
Sir, okay. I'm scrolling now. I'm provided with CT scan images of a trauma patient. I'll first scroll from top to bottom to look any obvious abnormality.
Yes.
The first apparent abnormality I could appreciate is subdural hematoma along right frontoparietotemporal convexity. In addition to that, I could appreciate subgaleal hematoma in the same region.
Okay, very nice. Okay.
Causing mild mass effect on the underlying brain parenchyma.
Yeah.
I'm looking for any intraparenchymal and intraventricular hemorrhage now.
Yes.
I think there is no intraventricular or intraparenchymal hemorrhage
Very nice.
seen.
Okay.
No significant midline shift is noted.
Okay. How can we determine the
Yes,
midline
sir.
shift, please? How can we determine the midline shift?
Sir,
Because
we
you
have
mentioned
to draw
now very important points, the midline shift.
Sir, oh, sorry.
No problem. Okay.
Sir, we have to draw a line from
Yeah. Okay.
from here to here.
I
and
will
then
help
we look
you. Just a minute. Okay. So keep the control with me, please. Okay.
Okay, sir.
So we will draw a line. Just a minute to remove this one. We will draw line like this one.
Yes, sir.
Is this at the midline? Okay.
Yes,
Then
sir.
next, what will we do?
So we'll look for any deviation of the ventricles and the thalami towards the other side, and we'll measure it.
I think it is now. Yeah, we should measure from the foramen of Monroe to the midline.
Yes, sir.
Okay.
Yes, sir.
So we have here about 4 millimeters. Okay. What else?
Sir, okay. I'm scrolling again.
Okay.
Sir, I could appreciate that there is.
Can you give me the chance to?
Yes, sir, it's jumping.
Okay, okay, no problem. Okay, this is, as you said, we have an extra-axial hematoma. Which type of hematoma is this one? Which
I
one?
think it's subdural.
Subdural hematoma, because we have here
tricentric shape and crossing
concave,
the sutures.
Yeah. We have concave surface of the hematoma.
Yes, sir.
Concave
Yes,
inner
sir.
surface. Is that correct? Okay. And
yes, sir.
Do we have any more data regarding this hematoma?
Sir, yeah, I think that there is low intensity signal noted within it.
Low signal
so
intensity
representing swirl sign and active bleeding.
Yeah. Swirl sign
and active
may
bleeding.
suggest active bleeding. Very nice. Okay. Very good.
Yes, sir.
Okay. And also this subdural hematoma is centered at the right temporal region, and we have also
then a bone window.
let's check the bone window.
Sir, on the bone window, I could appreciate a fracture involving the right parieto-temporal bone, causing the diastasis of the suture.
Very nice. Okay. So I would like also to add something here in the bone window. Do you have any more data that you want to highlight in any case of trauma? You described the hematoma very well, but you should also measure the thickness of the hematoma. Okay. This is about 5 millimeter in thickness. Okay. What else?
Sir, in addition to that, I could appreciate that there is mild hyperdensity along posterior fossa. It could represent trace subdural hemorrhage. Coup counter.
And counter coup. Yeah.
Yeah, but I couldn't
if we have
appreciate
any trauma here, you should search for any cerebral contusion on the opposite side, because the brain tissue will be pushed against the calvarial bones on the contralateral side. So you should mention, even if we have negative data, we don't have cerebral contusion on the contralateral side. Yes. What are the surgical indication for this hematoma? What is the landmark? What is the cutoff value? If we have any subdural hematoma, what is the cutoff value to be indicated for surgical interference?
Sir, I think more than 10 mm, not sure.
Yes, the thickness is more than 10 millimeter and the midline shift is more than 5 millimeter. Okay?
Yes, sir.
Very nice. Okay. Really, when we saw this one, we suggested that we have active bleeding because of swirl sign, and we did follow-up CT scan of the brain in the next day, and I think progression of the hematoma. So at this point, you should be cautious, because active bleeding is very important point that you have to mention in your report. Okay, thank you so much. Candidate number 2, please. Thank you so much. Can you please join me, Dr. Candidate number 2, only duplicated candidate number 2. Are you ready?
Yes, I'm ready.
Yes, you are ready. Okay. this is your case. Really, this case, I report this one. This is a child with severe headache. Okay.
Okay, this is an axial CT brain.
If you want to scroll, okay. If you want me to scroll for you as you like.
I want to scroll it.
Okay, go on.
Okay. This is an axial CT brain,
Yes.
non-contrast study,
Yes.
showing moderate hydrocephalic changes.
Yes.
Ventriculomegaly of the both lateral ventricles and third ventricle. I want as well as the fourth ventricle.
Yes.
I also see an space occupying lesion within the fourth ventricle of heterogeneous density, mixed hypo and iso as well as hyperdensity, causing expansion of the fourth ventricle.
Yes.
We also see mild periventricular CSF leakage.
Okay.
mild. I'm not sure is there or not, but some sort subtle or mild.
Maybe, but really it's not so obvious. But I think that we may have retrograde CSF permeation, but I'm not sure really regarding this point. Let's focus more on this space occupying lesion. As you said, the fourth ventricle is seen distended or expanded by virtue of large heterogeneous space occupying lesion, and the lesion shows, as you said, shows some cystic spaces, hypodense cystic spaces. Also, it shows few calcific fossae, and almost the lesion appears slightly hyperdense in relation to the rest of the brain tissue. And we have secondary hydrocephalic changes. What else?
There is no another space occupying lesion, either intraaxial or extraaxial, as an association.
Okay. We have also effacement. We have significant effacement of the cortex fossae, means that we have intracranial hypertension. So this one is not passive ventriculomegaly for sure. It is hydrocephalic changes. What else?
حاجة ممكن تفكر في differential diagnosis of the fourth ventricular mass lesion or complication of this mass lesion.
Okay. What else regarding the description before going to the differential diagnosis? What do you have here?
Description, we should search about is there association of complication cerebral herniation? Is there?
Yes. We have here crowded and obliterated CSF spaces as the foramen magnum. So we are suspecting cerebellar tonsillar herniation. Let's remove the sagittal brain. I think we have something like this. Really, I'm not sure, but we have something like cerebellar tonsillar herniation. Yes. Okay. What's your diagnosis, differential diagnosis? What is the next step?
Next step, can we? Is there MRI study for this child, doctor?
Okay. Next step, MRI study. I agree with you, but really, I don't have MRI study because it was an emergency situation.
CT post-contrast study or this study only?
This study only, really, because we did this one in the emergency room, and I think the patient was transferred to neurosurgical center. And also, I would like to emphasize that we have here diastasis of the sagittal sutures because of increased intracranial tension. What's your diagnosis? What's your differential diagnosis in this case? I agree with you that contrast enhanced MRI study is recommended in this case.
Yes.
And also, we should do, after stabilization of the patient, we should do MRI of the spine for searching for any CSF seeding or metastasis. Yes. Okay, give me a diagnosis and the differential diagnosis, please.
As regard the patient is young aged, we should consider الابنديموما والكرويد plexus tabelluma. This is not a cystic lesion, فمش هنفكر في في الكولويد سيست او الانترفنتريكولار سيست يعني كسيستيك وايز لا بنفكر في تيشو
So
ماس
we have
ليجن.
intraventricular tumor. You should think of ependymoma, medulloblastoma.
Yes.
Medulloblastoma is more common than ependymoma. Choroid plexus papilloma more common in the supratentorial part of the brain in the child age group, but in the adult age group, choroid plexus papilloma is very important in this side. But I think these classifications and this we have really some data suggestive of medulloblastoma. The hyperdensity is suggestive for what? For which one? Medulloblastoma or medulloblastoma? Yes. And the classifications is suggestive for which one?
More with ependymoma, I think.
Yes, you are right. Very, very nice. Okay, we will review these points later on. Okay, but I'm totally agree with you that the top differential diagnosis is ependymoma and the medulloblastoma, and I think it is complicated with huge or extensive supratentorial hydrocephalic changes for urgent neurosurgical consultation and shunt placement to remove the hydrocephalic changes. Okay. Yeah, to relieve the hydrocephalic changes. Thank you so much. Candidate number 2. Can we move?
Okay, you can scroll. Okay.
Okay.
So this is
as you like.
You can scroll, sir.
Okay, no problem.
So this is these are sagittal T2-weighted MRI images of the brain of a patient. There is a cystic lesion appearing as high intensity on T2-weighted imaging in the posterior cranial fossa, likely compressing the fourth ventricle and also causing mass effect on the brainstem. There is also the slight extension of this lesion into the through the foramen magnum. So I'm okay. This is on these axial images. I can appreciate that this is placed in the region of the fourth ventricle. There is a marked mass effect on the brainstem and also the pons. The resultant hydrocephalus is also as in this up till these images I can give differentials. It could represent epidermoid or reticuloid. However, as this is emergency, as the patient is developing hydrocephalus, so I will pick up my phone and inform the referring physician.
Very nice.
I will just refer to the neurosurgeon for VP shunting. After this lesion appearing hypointense on T1 weighted imaging. So I need to look for diffusion weighted and ADC imaging to see its characteristic features. It appears it shows a diffusion restriction supporting the diagnosis of epidermoid.
Yes. Okay. Very nice. Okay. So I think the case is straightforward with you. It's a difficult case. It's not so easy, but really well done. Because it is not commonly seen. We have an intraventricular multilobulated cystic mass lesion, and this mass lesion, as you said, it is causing a mass effect in the form of compression of the brainstem and spacing the brainstem anteriorly, also splaying the both middle cerebellar peduncles and indenting the cerebellum posteriorly and obstructing the CSF flow. So we have secondary moderate hydrocephalic changes, and as you said, one of the emergency causes. And as you said, that we are suspecting Epidermoid, and as we know that if we need to differentiate between Epidermoid and cyst, diffusion weight image is very important. My advice in this case for you in the exam, you may see a simple case or a simple diagnosis in a very rare location, as you see here. Okay, Epidermoid cyst, it is not commonly seen inside the fourth ventricle, but really well done. This is a straightforward case for Epidermoid cyst. Thank you so much. Can we move to candidate number 5, please? I'm sorry that I am not following the chat, but yeah, I think some of you wrote that we need to search for right mastitis. Right side, yes. Complication at right-sided hemorrhagic.
دكتور ممكن سؤال في الحالة دي بعد إذن حضرتك؟
نعم يا فندم، اتفضلي.
ممكن سؤال أنا بس ما سمعتش هو هل في اكستنشن للفورامين اوف لوشكا او انا ما سمعتش هل في اكستنشن ثرو
I think we have here small extension on the left side. Agree.
Yes, okay.
Totally agree. Okay. Welcome. Can we move to the next candidate, please? Candidate number 5. Where are you, candidate number 5? Are you, please, are you here? Are you available? Candidate number 5.
I think candidate 5 have attempted before candidate 2.
Okay, okay. Candidate number 6. Are you ready? Candidate number 6, are you ready? Okay.
Yes, Doctor.
Candidate number 6, are you ready?
Yes, I'm candidate 6.
Yeah, okay. Go on. We have here 45 years old patient with loss of consciousness.
Okay. I will just request a remote control.
Okay. Yes, go on. Can you scroll or no? Just a minute.
Okay.
Can you start to scroll now?
No.
Don't press the left click. Just scroll only. You couldn't scroll?
No, sorry, doctor. You can scroll for
okay,
me.
no problem. I will scroll it for you. Okay, no problem.
So
we have lots of. Yes, go on.
I'm presented with axial CT cuts without contrast for 45 years old male. I will take a moment to scroll from up to down.
Okay.
Then I will give my comment. Okay. But now I can't see any striking abnormalities. There is just some involutional brain changes. So the patient is 45. He's young. Okay. Yes, there is the adaptation of the third ventricle and cerebral acute.
Okay, so we have some a little bit brain involution changes.
Yes.
Okay, what else?
Checking the brain tumor.
Okay, so we don't have any brain tumors. We don't have any specific brain lesions. Agree.
Yeah.
Okay.
And I can't see.
We have acute deterioration of the consciousness.
Acute deterioration. Okay. I'm checking if there is any hypodensity, but I can't see any. So there is no evidence of acute infarction. Let me check the blood vessels. This is
checking the blood vessels, very important. Okay, before checking with the blood vessels, I think you excluded any hemorrhagic insult.
Yes, there is no hemorrhage.
Okay, so we are now checking the.
I think there is dense right MCA sign.
Dense right MCA sign. Yeah, we don't agree really. Okay. I think the right side almost.
Just more
is the same to the left side. Okay. What else should we check?
I can't see any infarction, no hemorrhage, no specific occupying lesion. Can I check the CP angle? Yeah. No effacement of the basal cisterns.
Yes, agree.
No effacement of the cell side.
You started to check the vessels and you started to check the middle cerebral artery. What else to finish? Checklist? Which vessel do you want to check more?
I want to check all the vessels, so we'll start with down from the vertebral and we'll go
okay,
up.
Go on, vertebral, okay, basilar.
The basilar. And see, I would like to check the internal carotid as well in the lower cut.
Okay, checking the basilar artery.
Yeah, this is the basilar appears fine.
Do you have any abnormality in the?
Sorry, the basilar appearance. Sorry, the tip of
yes,
the
very nice. Yes, well done. Yes. Well done. Okay, the tip of the basilar artery appears hyperdense as compared to the lower segment of the basilar artery. Okay, well done. Next step.
So I'm suspecting the. Next step, I would like to recommend CT angiography. Okay, yes, this is hyperdense. This is aneurysm, aneurysmal. Sorry, doctor, I would like.
Is the basilar artery is patent? Is the basilar artery okay or not?
Yeah, I can't appear patent, but at the tip I can't see it.
Yes, the lower portion of the basilar artery. This is a map image, axial map image. This is the patent lower segment of the basilar artery, and if you start to trace here, it appears totally occluded, and the posterior cerebral arteries on both sides are seen patent, and supplied by the hypertrophied posterior communicating arteries. So the posterior cerebral arteries are seen supplied by the anterior secretion, while the tip of the basilar artery is totally occluded. So we have hyperdense sign at the tip of the basilar artery, one of the most important signs and emergency signs, because this one is considered one of the life-threatening condition.
Yeah,
okay.
So I would
acute occlusion of the tip of the basilar artery. Okay, what's your next step?
I would like to combine my finding to the referral physician, and
yes.
I would refer the patient urgently to the stroke team.
Yes, and the intervention radiologist. May there is any chance for mechanical embolectomy, or at least injection or intra-arterial injection of thrombolysis. Okay, very nice. And so once we have any hyperdense sign inside any arterial branches or arterial tree, next step, you should do CT angiography for the patient to confirm and to measure a stenotic or occluded segment of the arterial tree and check the circle of Wells. And really the next step, as you said, calling the stroke team and calling the intervention radiologist, searching for the suitable way to manage the patient. Okay, thank you so much. Candidate number 5. Thank you so much. Can you go to?
Can I have a question?
Yes.
In the CT, doctor, the right perisylvian, is there right perisylvian hypodensity? A sign of early ischemia في الCT non-contrast.
Non-contrast. Okay. This one?
Yes.
This is partial volume.
This is a partial volume.
This is partial volume. This is partial volume. Okay.
Okay. Thank you.
As you see here at the left side. Okay.
Yes. Okay. Okay, doctor.
Okay. Let's go to candidate number 6. Candidate number 6. Are you ready, candidate number 6?
Doctor, I was number 6.
Okay.
So now it's turn for number 7.
Okay, number 7. I'm sorry.
Yes, I'm
candidate number 7. Number 7. How are you?
Alhamdulillah.
Pediatric patient.
Yes. This is an axial CT scan without contrast of a pediatric patient. The striking abnormality here is a large mass in the posterior fossa that appears to be centered at the fourth ventricle. It has both solid and cystic components.
Is it centered at the fourth ventricle?
It is actually in the right cerebellar hemisphere.
Yes, you are right.
In the right cerebellar hemisphere, and causing it appears to be causing compression of the fourth ventricle.
Yes, this is a compressed fourth ventricle.
Yes, compressed fourth ventricle.
Yes. Okay, very nice.
There is evidence of mild hydrocephalus.
Yes.
And The gray white matter differentiation is reduced.
Okay.
There
Yes.
appears to be like an element of brain edema.
Yes, totally agree.
Yes.
Agree. Okay,
And
so the gray white matter interface for a little bit, it is less distinct.
yes.
Okay, let's focus on the mass of the posterior fossa.
As this is a young child, so differential in this case would be pilocystic astrocytoma or medulloblastoma. No, but this is cystic component. Due to cystic component, it is less likely possibility.
Okay, but medulloblastoma, is it present inside the fourth ventricle or inside the cerebellar hemisphere? Is it interaxial or not? Medulloblastoma.
That should be in the fourth ventricle.
Yes, you are right. Okay. Okay. We will discuss this one in details. Okay. So we have here right cerebellar hemisphere. If I want to describe this mass lesion, I will say the right cerebellar hemisphere is the seat of a well-circumscribed complex space occupying lesion of mixed cystic and solid components. Okay.
Yes.
And as you said, that we should describe the mass effect compressing the brainstem anteriorly and compressing and displacing the fourth ventricle to the left side. And we have secondary hydrocephalic changes, as you said, and we did CT with contrast. And I think the solid component
is enhancing.
Yes. Okay. So you are suspecting pilocystic astrocytoma.
Yes.
Do you have any more differential?
Ependymoma should also be in the fourth ventricle.
Ependymoma and the medulloblastoma, it will
both
be
in the fourth ventricle.
Yeah, yes. You're right. Okay. Hemangioplastima, one of the differential, but it is really it is a remote possibility because of the age. Yeah, you are right. Okay. Metastatic lesion, also one of the differential diagnosis, but it's very rare in this age group. So the most logic differential diagnosis is pilocystic astrocytoma, and I think next step MRI study, contrast MRI study is recommended.
Contrast MRI plus which I will inform the clinician about the developing hydrocephalus, as it is an emergency and it should be.
Yeah, you are. There is one point lacking on. I want to hear it from you.
Yes.
One point, to finish the exam, perfect. One point. If you have pilocystic astrocytoma, what will you search for?
I would like to look for the image of the neuroaxis. And there is association with the NF1.
Yes, NF1. So, I need to hear you. Okay, yes, don't wait till the examiner asks you. Okay. There is a strong association between pilocystic astrocytoma and neurofibromatosis type 1. Okay, so you should search for any
other lesions in the
manifestations. At least in the CT brain, you should check the greater wings of sphenoid for hypoplasia or dysplasia.
Right.
Sphenoid and sphenoid bone and greater wings of sphenoid. You should tell the examiner that I am searching for any association. Okay.
Right.
That's good. Thank you so much. Candidate number 7. Can we go to next candidate, please? Candidate number 8.
Yes, sir. Hello. Yes, sir.
How are you, candidate number 8? Are you fine?
I'm good, alhamdulillah. Yes.
Alhamdulillah. Okay. This is 25 years old. Young adult patient complaining of epileptic.
Okay. So I'm presented with MRI brain axial sections, T2-weighted images of a 25-year-old patient. First, I like young adult patient. First, I like to have a look. Then I will start describing my findings. On the first look, I can see that there is no evidence of hydrocephalus.
Yes.
And yes, there is no evidence of hydrocephalus, and there are subtle T2 hyperintensities in the right periventricular, in the right frontal region in the white matter.
In the right side or left side?
Yes, on the left side, I can see that there is T2 hyperintensity. Yes, it's in the region of subcortical. It could be a subcortical tubers.
Yes.
And I want to see, yes. And on the flare, I can see there are multiple hyperintense lesions in the region of, in the subcortical regions.
Yes.
And also in the frontal and right frontal and left parietal, multiple. These are the subcortical hyperintensities, which is causing mild expansion of the overlying gyri, suggestive of cortical tubers. I will like to look if there's any evidence of subependymal nodules.
Yeah.
However, I cannot see any definite subependymal nodules, and no as giant cell astrocytoma is noted at present.
Yes.
But
yes, we should search for any space occupying lesion at the foramen of Monroe. We don't have any masses. We don't have any subependymal nodules, and I am totally agree with you that this is very characteristic for tubers, cortical and subcortical cerebral tubers.
Convey my findings to the referring clinician, and will advise examination of the eye to look for any retinal angiomas, or also
very
of
nice.
the triad of
very
mental
nice.
retardation, or any skin lesion of adenoma sebaceum, and any history of seizures. And also will advise evaluation of the kidneys, and also echocardiography for any cardiac rhabdomyomas.
Okay. Very nice. Okay, to check also the lungs and doing abdominal ultrasound. Okay, that's okay. So you are searching for any manifestations of
MRI. I think annual follow-up MRI to look for any developing giant cell astrocytoma.
Follow-up is very important to check development of giant cell astrocytoma along the foramen of Monroe. Just I would like to add something. I think it's very odd, or it's very we don't have any really definite or logic differential diagnosis here in this case. It doesn't look like MS or encephalitis or something like this. I think it is very pathognomonic for tuberous sclerosis. What do you think? I would like to read the chat. Hemangioblastoma F syndrome association in this age. Yeah, you are right. Dr. Khalid mentioned very important point. I will mention this one later on. Dr. Khalida, sorry. Dr. Khalida, I'm sorry. You mentioned very important point. Hemangioblastoma is common in the adult age group, but unless we have von Hippel-Lindau disease, hemangioblastoma can occur in the pediatric age group. Agree, totally agree. Cortical amyloidosis, pilocystic carcinoma. Okay, I think all of you are doing 15 years old.
Yes.
Child.
Yes.
And really, this case, when I saw this case, the patient came to the ER complaining of abnormal gait, and really the ER staff managed the patient, and patient came again to the ER complaining of a new attack of abnormal gait. So the referring clinician requested to do non-contrastive scan of the brain. Okay, so go on if you want to scroll.
Yes, sir, I'm unable to scroll in.
Okay.
So mobile. Okay, so it can provide with CT scan X-ray images without contrast when young patient, 15-year-old with ataxia. So I can appreciate there is some prominent extra specific axial spaces which is inappropriate with the age of the patient, like might of the children. Apart from this, I have a small hypodensity frontal region, frontal lobe. So I want to see frontal lobe. Yes, sir. There is some cortical white matter hypodensity in right frontal lobe.
In the right ventricle?
Yes.
What do you have in the right?
White matter.
In the?
Yes, sir. Why hypodensity within the right
Hypodensity,
frontal lobe?
where is this hypodensity?
It's a subcortical white matter.
Subcortical? Okay.
Yes, yes.
In which
Yes,
region?
sir.
Right
Yes,
side or
right,
left side?
right side, right side.
Right side?
Yes, this maybe, sir, volume affects this one.
Do you here?
Yes, sir. Yes, sir.
Okay.
Okay. Apart from
Is that
this,
considered abnormality or not? I don't know.
Okay.
What else? Okay. But I agree with you. Okay.
Okay.
Well done. Okay.
Okay.
But do you have any more obvious abnormality? Because you mentioned the less obvious one, but do you have any more abnormalities?
So apart from this, so I want to check limbic system as well as insular cortex and temporal lobe.
Can you check again, please, subcortical white matter as you did here, because you caught or you picked up the most difficult one, really, because this one is true. Okay, I agree. Because I think we can, once we have something like this, okay, we should play or modify the window. We have something abnormal on the right side. Totally agree.
Okay. Sir,
do you have any?
Sir, I feel there is a gyra seems to be crowded. I'm suspecting some poly gyra. I feel there's a crowding of gyri.
Okay.
And yes, sir. Left temporal lobe, I want to
Yes, you are right. Yes, you are right. The left temporal region shows subcortical hypodensity area as well. Yes, all right. Really, it is a challenging case, and you are doing very well. Okay, what else? I think also we have here something very ventricular hypodensity. So, in conclusion, yeah, we have multifocal, multiple, scattered, subcortical, ill-defined, hypodense patchy areas, right frontal, left temporal. Okay, what's your opinion?
Sir, I want to further check these in the coronal images as well, and I want to check in the contrast images as well. This is a child, so I'm suspecting some like infective encephalitis as well.
Agree.
Any history of recent fever or vaccination or anything?
Yeah, the patient, when we asked the patient complained of acute chest infection 3 weeks ago.
3 weeks ago.
Yes.
So then I also have another differential of Adams as well. Acute disseminated.
Yeah, Adam. Okay. Acute disseminating encephalitis. Yeah. One was a differential. What else? But you are thinking in a very logic, systemic way. Well done. Okay. What else? Okay, I think it's difficult to say more differential diagnosis in this age group. But Adam is one of our differential diagnosis. What is your next step? Much better than contrast enhanced study. Yeah.
Yes, contrast. So MRI would be
MRI. Okay, I will give you the MRI. I will show you the MRI.
Okay. Yes, sir. There are multifocal areas of clear hyperintensities which are rounded within the subcortical as well as paraventricular white matter of this patient. These are rounded and with the paraventricular as well as subcortical white matter, and it's supratentorial as well as I want to check infratentorial as well.
Okay.
Sir, these. Okay, sir. Sir, I also want to check the sagittal image of this patient.
Okay, I will show you the sagittal image. Very nice. Okay, this is the sagittal image.
Yes, sir. So these are multiple rounded region which is involving the corpus callosum of the patient and projecting perpendicular to the corpus callosum.
Yeah, callosoceptal interface. Do you agree with me? The callosoceptal interface. Okay. And I think most of the lesion show perpendicular orientation to the ventricular system. Okay.
Yes, sir. Sir, I
Okay.
also want to
What's your
check on,
diagnosis?
sir, in this multiple sclerosis is my top differential, but I also want to check on diffusion weighted as well as contrast, which
Okay.
is for active and
Okay.
as well as chronic. Yes. Yes, sir. So a few of them shows also restriction. I also want to compare with the ADC, but on these images,
Okay.
the
You
right
can
side.
check. I will give you the ADC beside. Where is the ADC here? There's ADC. Okay.
Yes, sir. Yes, ma'am. The area within the left paraventricular will show some diffusion restriction.
Yeah, this one showing restricted diffusion.
Yes,
Agree.
restriction.
Okay.
Yes, sir.
And I think also this
the
area
patient is
shows
saying,
restricted diffusion
yes, yes.
along the
sir,
right
yes.
aspect of the
Diffusion
bones
also.
and right middle
Bones.
cerebellar peduncle. Okay. What's your diagnosis?
Okay, sir. Sir, patient first, the appearances are radiological appearance more likely this multiple sclerosis.
Yeah,
But
agree.
I also want to know about the history, like it's in time space, like any previous imaging or previous episode of these type of
Okay.
imaging as well.
So yeah, I would like to thank you so much because this is one of the challenging cases. Really, when I started to report this case, I was in doubt. Are those abnormalities are really abnormality or not? And really, I report this one as I am suspecting different or multifocal hypodense patch areas, and I recommended to do the MRI study. And once we did the MRI study, we found that we have typical criteria of MS: perpendicular orientation, callous septal location, and also some of the lesions show restricted diffusion. And those are the characteristic sites of the multiple sclerosis. Multiple sclerosis, we have 4 characteristic locations: cortical, subcortical, 1, and we have also callosoceptal, and we have posterior fossa and spinal cord. Okay, and also the optic nerves considered one of the locations that you should search for any plaques. And I think in the corona T2, it's very important to check the sites of the multiple sclerosis. But I would like to ask you, because you mentioned Adam, acute disseminated encephalomyelitis is one of the differential diagnoses in this age group, because in the pediatric age group, Adam is more common than multiple sclerosis. Let's check the basal ganglia. The basal ganglia on both sides are not affected. Yes. And Adam more commonly affecting the basal ganglia, and free basal ganglia, it is supportive for multiple sclerosis because the basal ganglia are normal in signal intensity. I would like also to highlight that once we have low signal intensity in the T1 weight image for the region, look for this area. For example, low signal intensity in the T1 weight image is prognostic. It's of bad prognostic value. We call it black holes in the multiple sclerosis. How can we determine the activity? As you said, restricted diffusion, contrast enhancement, and also
edema also.
Yes. Thank you so much, Candid.
I am provided with the multi-sequential MRI of the brain, and this is two weighted images axial section, in which I can, the first striking abnormality on the first glance that I can see that there is a well-defined ISO2 hyper intense lesion noted in the right cerebellar hemisphere. It is not causing any significant, it is causing mild significant mass effect. However, it is not causing any shift. It is not differential intensities within it also. Now I will scroll rest of the images to look for the multiplicity of the lesion.
Yes, very nice.
So upwards, there is mild dilatation of the ventricular system and the extra spaces also that can be age-related involutional changes, but if the patient is adult, old age patient. Some prominence of VR spaces is also noted. Okay.
Yes, I agree with you that we don't have any other lesions.
Okay,
and
sir.
Yeah, this is the most.
So I will like to see it on other sequences as well.
Okay, let's move to the next sequence. Just a minute, please.
Okay, sir.
Just a minute. Okay.
These are FLAIR images, coronal section, in which the lesion is showing relatively hyperintense signal return, and is noted in the cortical gray matter, basically. So it is a cortical lesion, which is causing mild expansion of the cortex as well, and also causing mild mass effect. However, no midline shift is noted. So I would like to know about the history of the patient, if there is any history of fits related to the patient. I would like to keep the differential.
Yeah, we don't have any history of fits.
Okay, sir. Okay, sir. On sagittal T2 images, same lesion is redemonstrated. And is again iso to hyperintense relative to gray matter.
Okay.
It seems like some cystic sort of lesion, but it is not following the perfect signals of fluid. So can I see the diffusion restriction?
Okay, this is the diffusion.
Okay, and on diffusion restriction, it is showing partial restriction.
Okay.
Okay, I will compare it with ADC.
What do you think? Is it restricted?
Partially it is showing restricted.
One part of it is not significantly restricted.
Okay, not significant restriction.
Okay. I want to localize or focus here, please. Is it intraaxial or extraaxial?
Sir, as it is...
I know that the position or the location, it's very difficult and it's odd. It's not common. But
Yes,
let us think together.
Okay, sir. Sir, if I see other features as it is compressing the brain parenchyma, it seems that it is extra-axial, I guess.
Extra-axial, yeah,
yes.
I agree. Yes, I agree. We have here two signs that are suggestive of extra-axial location. We have, this is the CSF left sign.
Yes, sir. So it is basically extra-axial CSF cleft sign, basically.
Yes, also we have here, we have buckling of the cerebellar folia above the lesion, yes.
So it's meningioma, basically.
So it's extra-axial, yes, agree. Okay, so extra-axial lesion, what's your differential diagnosis?
So meningioma, first is meningioma.
Okay, very nice.
The second can be dural mets, but it is not causing...
very nice. Very nice, okay. I think those are the top two differential diagnoses. What's your next step?
Sir, I would, so as there is no multiplicity of the lesion noted, so first differential would be meningioma. But sir, I would like to see on, sir, I guess I would refer the patient to the neurosurgical department for further.
Okay. Do you think that the contrast enhanced study will be helpful?
Okay, sir. If there is available, please show me this.
Okay. Also. Let's see. What I think this is.
Okay, sir. It is showing intense enhancement, intense smooth enhancement.
Homogeneous enhancement. Yes.
Homogeneous enhancement.
Yes.
Strong
intense homogeneous enhancement, and we don't have any other lesions. And
yes, sir.
Let's go to the coronal pain. I think this is a coronal pain.
Okay,
yeah,
sir.
it is
demonstrating the dural tail sign also.
Yeah, okay. There is small dural tail sign. Well done. We have here very subtle dural tail sign. If you want here to focus more, So this is a dural tail sign, as you can see here and here. Okay. Okay. So it's pathognomonic now that we have
a meningioma.
A meningioma. Yeah. Do you know what is the name of this meningioma?
What is the name of meningioma?
Yes, yes.
So, cortical
it's
meningioma.
It's cerebellar convexity meningioma.
Okay, sir. Okay, sir.
Cerebellar convexity meningioma.
Convexity meningioma. Okay,
yes,
sir.
That's okay. Thank you so much. Candidate
Sir,
number 10.
My comment.
Yes.
So what I can see here is there is soft tissue edema.
Cover the whole brain, please. Cover the whole brain.
Okay, okay. So I'm going to the top. Okay. So can I know about the history of the patient?
Yeah. This is a trauma patient.
Okay. So so I can see here that there's the subgallial hematoma overlying the right parietal.
Yes, parietal. Okay.
Bone extending to the left side.
Okay.
And there seems to be underlying bone fracture, but I will confirm on the bone window.
Okay.
And there is underlying extraaxial. I'm trying to check. Seems to be subdural hematoma. And CSF smearing.
Yeah, you are right. We have a smearing
parietal, which
of the CSF at the right
this is
high parietal
subarachnoid
region. Yes.
Yeah, of the right high parietal, so the subarachnoid hemorrhage.
Okay.
So I would like to check for the countercoup lesion on the opposite side, which I can't see. Anything in the left frontal.
I'm sorry to disturb you, but I would like to emphasize one point here, please. For all the audience, the countercoup is more likely to appear at the temporal region. Okay. So once we have any cerebral contusion here, and the trauma is going from the back, from the occipital or posterior parietal region, the countercoup is more commonly seen as the temporal region because the brain tissue is compressed against the greater wing of the field. Okay, but this is a point away from our discussion. I'm sorry to disturb you, and let's focus again on this area. Just I would like to show you the coronal. Okay, this is a coronal plane for the same lesion. Okay. Okay.
So
scroll as you like.
Okay, so this is the coronal sections. I would like to check again the extraaxial hemorrhage for better demonstration. Sorry. And to check for any midline shift as subfalcine herniation.
Very nice. We don't have any subfalcine herniation. Do you agree?
Okay. I will have a look again. I can see any subfalcine herniation, and also checking for any transtentorial or there is no.
We don't have any brain herniation.
Yes. Okay.
Let's focus on the side of the trauma, please.
Okay. Okay. Okay.
Do we have subarachnoid hemorrhage as you said?
It's not well appreciated in the coronal. So it's more to be subarachnoid.
Yes, it's subarachnoid hemorrhage. It's not subdural
Yeah.
hematoma. Okay.
Okay,
So we have
there's no
smearing of the
hemorrhage
CSF
alone.
by blood density. And what do you want to check more?
I'm just checking if there's any other
We don't
hemorrhage.
have any other abnormalities. Don't worry.
Okay.
But you are going well.
Okay.
Yeah, we are doing. You are doing well. You should check everything
Okay.
in case of trauma. But to save your time, we don't have any
Okay.
other abnormalities.
Okay.
What else?
So I would like to check the brain window, please.
The bone window. Okay.
Sorry, the bone window. Sorry.
Just a minute. I will give
Because
you.
I suspect that it's a depressed fracture.
Yes, you are right.
Okay. Yes, it's a depressed fracture.
It's
So,
depressed fracture. Yes.
Yeah. It doesn't seem to be to exceed the full length of the Calvarial bone.
Very
Yeah.
nice. Okay.
But I will measure the distance.
Yes, we will measure the distance between the inner table
Okay.
here and inner
Yeah.
table here.
Okay.
I think it is more likely to be something like 2 millimeter or something like this. I think it is not so significant. Yeah.
Okay. Okay.
Okay. So well done. So we have here a depressed bone fracture involving the right high parietal calvarial bone, and we have underlying subarachnoid hemorrhage. I would like also to add something very important. As you said, we should measure the length of the degree of the depression between the inner table to the inner table of the depressed bone fragment. And once we have, if we have something like this is calvarial bone, and this is another calvarial bone, if it is depressed or passing the full or the whole thickness of the calvarial bone, this is considered one of the potential indication for surgical interference. Yes, if we have the depressed bone segment more than 8 to 10 millimeter, it is considered one of the indications of the surgical interference. If we have any focal neurological deficit, it's considered also one of the indications for surgical interference. Also, the subarachnoid hemorrhage, we are classifying the subarachnoid hemorrhage into traumatic subarachnoid hemorrhage and non-traumatic subarachnoid hemorrhage. The non-traumatic subarachnoid hemorrhage more commonly seen at the base of sternum, and more commonly the cause is rupture aneurysm or AVM or something like this. And the traumatic subarachnoid hemorrhage more commonly seen at the periphery of the brain, as you can see here. And we have also something called modified fissure scale for grading of the subarachnoid hemorrhage. If we have subarachnoid hemorrhage very thin, as you can see here, and it doesn't extending into the ventricular system, so this one is grade 1. Grade 2, if it is extending to the interventricular system. Grade 3, if we have thick subarachnoid hemorrhage without extension to the interventricular system, this is grade 3. And grade 4, thick subarachnoid hemorrhage extending to the interventricular system. Okay, so I think you completed all the findings that we have in this case. Thank you so much. Candidate number 14. We have a young adult patient, 30 years old.
Okay. Okay. What is the patient history?
Headache.
Headache only. Okay. I've been provided with axial cut MRI brain for T1 image. Just I will have a look and then I will comment from upward to downward. Okay, I can see that there is maybe abnormal hypointense signal noted within the fourth ventricle.
Yes. Okay, agree. We have something abnormal inside the inferior part of the fourth ventricle.
Okay. Yes, I want to look for it in T2. and also in post contrast. Okay. In T2, the lesion that I saw with low intense signal in T1, it appeared to be heterogeneous signal in T2. It show hyper intense signal, and also it can we focus on it? Yes, yes. It's a hyper intense signal mixed with hypo intense, show also a signal of edema. The edema, yes, it has surrounded edema. Okay.
Agree.
I want to look for it in post contrast to see if
do you have any complications for this space occupying lesion apart from the compression and edema signal of the surrounding brain tissue?
Yes, I can see that there is dilatation of the both temporal lobes of the lateral ventricle, suggesting that there is evidence of.
We have very subtle dilatation of the temporal folds.
But
so we have
this is going to be early hydrocephalus.
Very early. Okay, totally agree. Okay.
I want to look for this in sagittal view and in post contrast.
Okay, I will show you the sagittal plane, but before going to the sagittal plane.
Okay, this is a post contrast. I can see. Okay, there is evidence of contrast enhancement.
Intense contrast enhancement, heterogeneous contrast enhancement. Okay.
Yes, in the sagittal view, I can see it cause compression of the fourth ventricle. I couldn't see. I couldn't see that there is evidence of brain herniation or tonsillar herniation.
Yes, very nice.
No other lesion I can see in meninges or in the neural axis in the cervical in the spinal cord.
Okay.
The lesion. Okay, so I want to put differential diagnosis for this lesion. It's a lesion, mixed solid and cystic component within the fourth ventricle of an adult patient. So there's also evidence of maybe calcification within this hypointense signal that noted within. Maybe this is ependymoma. The main diagnosis for this could be ependymoma.
Ependymoma, okay. Yes,
also,
I agree. One of the differential diagnosis of the intraventricular mass in adult age group, ependymoma, posterior fossa ependymoma. What else?
It could be METS.
METS, maybe. Okay.
But less likely to be
difficult, but okay. What is more logic?
I couldn't say only ependymoma in this fourth ventricle and maybe astrocytoma, but also in less likely in the interventricular in this adult patient, so we couldn't say it's a medulloblastoma. Maybe subependymoma. But
subependymoma, one of the differential diagnoses. What is against subependymoma?
It should be subependymoma. I think will not show calcification, and it will not be in the fourth ventricle. I think it should be in the lateral ventricle. As
the subependymoma can be along the inferior aspect of the fourth ventricle and besides the cerebellar tonsils near the foramen magnum. This is the most specific sites for the subependymoma, but this case it is not subependymoma. Can you give me?
Because also it shows contrast enhancement.
Yes, very nice. This mass is avidly enhancing.
Yes.
It could be subependymoma. It will not show significant enhancement. Most of the cases, the typical form of subependymoma, it will not show significant.
It could be choroid plexus.
Yeah, totally agree. Okay, this is the most logical. Choroid plexus papilloma. More common at the posterior fossa in adult age group. In child age group, the choroid plexus papilloma is more common.
In the lateral ventricle.
Yes, in the lateral ventricles. And subependymoma, most of subependymoma is not enhancing, but we should put in our differential diagnosis ependymoma and subependymoma. You are right, totally correct. So we have here a case of choroid plexus papilloma. Very nice. Thank you so much.
Thank you.
Candidate number 15. Can we go to candidate number 16. By the way, this is a very similar case. This is a space-occupying lesion at the lower part of the fourth ventricle at the side, and the mass lesion doesn't show significant contrast enhancement. So our top differential diagnosis in this case is sub-ependymoma. Okay. Thank you so much. Candidate number 15.
No, I'm good.
Okay.
I
Go on.
have presented with axial T2.
I couldn't hear you very well. Can you please raise your voice?
I have presented with axial T2 MRI.
Yes. Okay. Very nice. Okay.
At the posterior fossa level.
Okay.
Going forward to supratentorial levels, then back again, there is left-sided posterior fossa cerebellar cortex-based cystic lesion that is had.
Yes.
Intramural eccentric cortical site isointense lesion that showing isointense with no calcification, with no significant wall thickness in this mass, surrounded by vasogenic edema. This is showing
very nice.
Post-contrast intense enhancement. If the patient is
this is the axial flare, okay? We don't have still this is
axial flare also showing the vasogenic edema and hyperintense peripheral eccentric nodule. If the patient
very
is
nice.
child,
so we have cystic space occupying lesion at the left cerebellar hemisphere with an eccentric nodular soft tissue component or nodular solid component, and it is surrounded by vasogenic brain edema, exerting mass effect in the form of mild encroachment of the fourth ventricle.
Yes.
Okay, what else? Is it intraaxial or extraaxial? What do you think?
This looks like intraaxial.
Yeah, intraaxial, yes. This is this is the cerebellar tissue. I think it is more to be intraaxial. Okay, let's move to the post-contrast.
Post-contrast
series
showing post-contrast series in coronal showing intense contrast enhancement with no other other lesions. There is no multilocularity or multicentric. It is a single lesion.
We don't have also significant hydrocephalic changes. Do you agree? Okay.
Yes.
Okay, so we have intracerebellar or intraaxial cystic space occupying lesion with eccentric enhancing nodular solid component. What's your diagnosis?
Diagnosis if the patient is a child, and means will be hemangioblastoma. If it is adult, maybe it is ganglioma, but it's usually coming in the temporal lobes or the frontal
Again,
lobe.
please, if the patient is a child, we should think of hemangioblastoma is more common in the adult age group. Okay, unless we have von Hippel-Lindau disease. Okay, but the typical age group for the hemangioblastoma is a young adult and the adult age group. Okay, hemangioblastoma is not common in the pediatric or child age group. Okay, the more common if we have cystic lesion.
Pilocystic astrocytoma.
Pilocystic astrocytoma. Yes, you are right. So pilocystic astrocytoma is more common than hemangioblastoma, unless we have von Hippel-Lindau. This another situation. Okay, so the most logic thinking here, because this is a young adult patient, the most logic diagnosis here is hemangioblastoma. Okay, so once we have also hemangioblastoma, there is strong association with von Hippel-Lindau, so you should search for other manifestations of von Hippel-Lindau. You should check the eye group, retina, and we should check also the abdomen for any renal masses and all of these manifestations. Okay, thank you so much.
Thank you.
Candidate number 16 or 17? 17. Okay,
17
next candidate, please. Okay, next candidate. Next candidate. Candidate number 18. Candidate number 18. Candidate number 19.
Yes, sir. I'm candidate 19.
Candidate number 19. How are you?
I'm fine.
I'm sorry that you waited for a long time with me.
No problem.
You may be exhausted. Okay, candidate number 19.
Yes, sir.
Okay, go on.
So this is an axial brain MRI study in T2 sequence. I can say that there are multiple and bilateral and nearly symmetrical white matter foci, abnormal signal, hypersignal foci within the deep white matter, and the periventricular region appears to be of a perpendicular orientation on
Very
the
nice.
lateral ventricle horns.
Yes.
And I can't see if, and there's also some involvement with the corpus callosal as well. I want to check for the distribution of these foci on FLAIR for better assessment. And there is a left-sided cerebellar Lermite-Douglas lesion as well.
Yeah, wow, very nice. You got the diagnosis straightforward. We have dysplastic cerebellar gangliocytoma. Yeah.
Yes.
How did you identify this mass lesion? What is your characteristic signs?
It has a characteristic appearance. It has a tigroid pattern of alternating hypo and hyper signal
or striated pattern.
Striated
pattern. Yeah, it's very characteristic. What is the
has
strongest?
No mass effect and surrounded edema. Yes.
Yes.
And the cerebellum is a typical site.
Yes, very nice. So we have here multiple sclerosis with coexisting dysplastic cerebellar astrocytoma or gangliocytoma. Gangliocytoma, not ganglioma. Okay, take care of this point. And the strong association with this mass lesion is Cowden syndrome.
Cowden syndrome, yes.
Yeah, Cowden syndrome, and you should search for any hematomatous affection elsewhere in the
within the body or the bowel, and there's also with breast cancer as well.
Okay, breast cancer and also thyroid cancer. Very strong association. Okay, thank you so much. Candidate number 19. Do you have any more candidates? Yes. Okay, go on. If you want to scroll.
No, sir, you can scroll for me, please.
Okay.
Okay, this is an axial CT brain native study. I can see that there is an heterogeneously but predominantly hypodense mass within the posterior fossa, midline of aspect of the posterior fossa.
Yes.
It is predominantly hypodense with a foci of hyperdensity within it, causing an upstream. I want to check if there is like an upstream ventriculomegaly.
We don't have any significant.
No, we don't have any significant ventriculomegaly or like external dilatation.
Yeah.
I want to assess for any transtentorial or tonsillar herniation for this as well.
You are right. Okay. I think we don't have any transtentorial.
There is no transtentorial herniation.
Yeah, but I think
the bulk of the lesion appears to be within the brainstem mostly, and
very
it is
nice.
effacement of the fourth ventricle.
Yes.
Yes, and it's widened and prominence of the basilar cistern above it. It is of intermediate or hypodense signal or hypodense in character, and with surrounding prominent peritumoral edema as well.
Okay, what do you think? Is it infectious disease? Is it neoplastic? Is it congenital? Is it toxic?
I don't know. I wasn't provided with the age of the patient, but the
age of the patient is 10 years.
10 years. Yes, if it's 10 years, so I would go with a congenital tumor.
Congenital what?
And congenital tumor. It's
congenital tumor.
So
tumor.
Yes,
not congenital. It's a tumor. Okay.
Yes,
okay.
It's a tumor.
Which type of tumors? Which type of tumors do you think?
Round cell tumors. This the one that arise mostly from the posterior fossa and the brainstem. This one could be diffuse myoma. The mass is hyper intense on T1, on T2.
Okay.
There are no cystic changes within it as well.
Yeah.
I want to see the post-contrast also enhancement pattern.
Really,
And
we injected the contrast. Yeah, we injected, but really, unfortunately, I don't have the post-contrast series, but it doesn't show significant contrast enhancement.
If it's not significantly enhancing, then it was mostly with low-grade glioma or diffuse.
Yeah, very nice. Okay. Yes, diffuse pontine glioma. It's considered as a low-grade glioma. And really, in my routine practice, I saw this one maybe 4 or 5 times over the 25 years of experience. It is relatively, or it is not common, but really, once you saw this one, it's very characteristic, very pathognomonic. It's extending to the 2 cerebral peduncles on both sides, but more on the left side. And the bones is markedly distended by the space-occupying lesion and partially engulfing the basilar artery. We don't have any significant supratentorial ventricular dilatation or hydrocephalic changes. So this is the most logic differential diagnosis is diffuse pontine glioma. Okay. Would you like to have one more case or not?
Doctor, please.
I have one more. I would like to emphasize some important points. As you know, or as you saw or watched with me, that I focused today on the posterior fossa lesions. Once we have posterior fossa mass lesions, we should think medulloblastoma, pilocystic astrocytoma, posterior fossa ependymoma. Those should be differentiated. We will discuss how to differentiate between medulloblastoma and ependymoma. Pilocystic astrocytoma, cystic mass lesion with solid nodule, and in the adult age group, the opposite for this one is a hemangioplasma. Also, brainstem glioma, atypical teratoid thromboid tumor, it's less common. Hemangioplasma less common unless we have bone heavy endow. Teratoma is less common. Those are the most important differential diagnosis. We have also in the adult age group choroid plexus papilloma, avidly enhancing mass, as we saw before. Posterior fossa ependymoma, it's less common. Subependymoma, most likely not enhancing. Hemangioplasma, as we said. Cerebellar metastasis, dysplastic cerebellar gangliocytoma, as we saw. Schwannoma, more common at the internal auditory canal and cerebellopontine angle. Meningioma, we saw a case of meningioma. Epidermoid cyst, we saw a case of epidermoid cyst. Lipoma also. Those are intraventricular. Those are intraaxial, and those are extraaxial. So those are intraaxial inside the cerebellar hemispheres, and those are extraaxial. Okay. I would like also to add something very important. For me, if we have a case of medulloblastoma or ependymoma in pediatric age group, how can we differentiate this part? Medulloblastoma, remember, high signal in diffusion and high density in CT. Okay, so we have 2H. High signal in the diffusion with image because of high cellularity, restricted diffusion, and high density in the CT. Okay, regarding the ependymoma, it appears from the floor of the fourth ventricle, not the roof, and can extend to the foramen of Loschka. Okay, so it is considered as a plastic tumor. It starts to creep inside the foramen of Loschka. Okay, so we have here 2F. Of course, the ependymoma arises from the floor of the fourth ventricle. The medulloblastoma arises from the roof, not the floor. Okay, we have also cysts and calcifications. 2C. Cysts, 50%, almost the same. Calcification is more common. around 50% here, but here it is about 10% is medulloblastoma. So once we have calcifications, it's more common in ependymoma. Once we have high signal in diffusion, high density in the CT, more common in the medulloblastoma. Both of these lesions, you should check the CSF seeding, okay? Also, the ependymoma, it's more common, or we have high risk of spontaneous bleeding, okay, for the ependymoma. Those are my keywords, how to differentiate between medulloblastoma and ependymoma, okay? Let's go to our next case. This is one of, I have 2 cases only, more if you want to continue, or if you want me to stop here, but I'm ready to continue if you want. You can write for me in the chat. I can continue for 10 minutes more. 10 minutes more to cover the last 2 cases. Okay. Do you agree?
Yes, we want. Yes.
Continue. Okay, that's good. Okay. Who is ready to discuss with me this case?
Me. Okay.
Okay. Are you ready?
Yes, please.
Yeah, go on.
Yes, I have provided by sinus slices, axial cuts, high T2,
okay.
high resolution T2, cyst, or
cyst or vista. Okay. Okay.
It's seeing that there is a mass lesion middle line centered over anterior to the prepontine in the prepontine system, overlying the basilar artery.
Okay.
I'm sorry, this is like a delcoctatic vertebral artery, but there is
this
right-sided.
We have here, as you said, we have a small lesion at the right intracanaliculaar portion. Yes, okay.
As there is a mass in the right intracanaliculaar portion of internal auditory canal that is creeping over the vestibulocochlear intercourse, and facial nerve.
Okay.
So this could be vestibulocochlear schwannoma or facial.
Okay, right side acoustic neuroma or schwannoma. Okay. What else? Do you have any more abnormalities? Is the fourth ventricle is clear?
Yes, there is intermediate.
Yeah, it's difficult, but I think there is something here abnormal.
So
okay.
This looks like a vascular or hyperintense lesion.
Avidly enhancing mass lesion. Yes.
Avidly enhancing mass
inside
lesion.
the inferior portion of the fourth ventricle. And we have also, as you said, we have another lesion at the right internal auditory canal.
Okay.
We don't have any other lesions. Let's focus on these lesions. What do you think?
Unilateral schwannoma and maybe ependymoma in the fourth ventricle?
Yeah. Yes, yeah, it's very logic to be this one, maybe ependymoma, maybe acoustic neuroma. Agree. If we have neuroma and ependymoma, we will think of neurofibromatosis type 2. If suppose that this one not ependymoma, what's your differential diagnosis?
Metastasis.
What are our differential diagnosis? As we said in the last slides, in adult age group, intraventricular mass, we have choroid plexus papilloma, ependymoma, subependymoma. Do you think is that this one may be subependymoma? It's not typical, maybe, but it's not typical because it's enhancing. Yeah. So the most logic differential diagnosis is choroid plexus papilloma. So this one may be ependymoma. If it is ependymoma, you should think of neurofibromatosis type 2. If it is not ependymoma, maybe choroid plexus papilloma. And this one was proved as choroid plexus papilloma with coexisting right side acoustic neuroma. Okay? Thank you so much.
Thank you.
Thank you so much. We have or any candidates. Anyone wants to share with me?
Yes, I can.
Okay, go on. What We have right-sided hemiparesis. This is one of the most common findings. I have many cases like this, but we need to apply something very important in this case. Right-sided hemiparesis, what do you think? Do you want me to scroll or you want to scroll by yourself?
Yes, doctor. I can scroll. I will try to scroll.
Okay.
Okay.
Okay, go on.
Okay. Sorry, the history of this patient again?
Right-sided hemiparesis, acute.
Okay. I've been provided with axial cut CT brain for a patient without contrast. I can see that there is evidence of multiple hypodense lesion noted within the left basal ganglia and also the left parietal cortical and subcortical region.
Okay.
I couldn't see any other abnormality noted within the brain parenchyma. Just I will go down to the last cut. Okay. I couldn't see that there is evidence of there is evidence of no midline shifting, no brain herniation noted, and also I couldn't see that there is evidence of compression of the ventricles. So and also no evidence of hemorrhage noted. So this could be acute. This could be evidence of this could be infarction, but I should put differential diagnosis for this could be glioma or astrocytoma. Also, I need to check this in MRI or CT with contrast, and to check that.
How can we confirm that this one is the ischemic insult or neoplastic?
The ischemic insult mostly will be in the vascular territory.
Is this territory? Yeah, you are thinking very well. Is this a specific territory?
This is a middle cerebral artery. Could be the middle cerebral artery as it involves the left basal ganglia.
Yes, you're right. It is a territory. We have loss of the white matter.
I will be sure about this by the diffusion in MRI.
Okay, before diffusion, we need to collect as much as we can from this.
Yes. Okay.
You are suspecting a stroke. You are suspecting infarction.
Yes.
What should you do?
What should I do? I think if this patient with CT, do you mean that with this scan specifically, or
yes, in this CT brain?
In this
you are thinking that we have acute infarction along the territory of the left
middle cerebral artery. Left middle cerebral artery.
Yes, it's logic.
Okay. Just what should I do with this CT? I'm thinking if I give this patient a contrast, it will differentiate between the infarction and if this is another lesion. But according to the sudden symptoms and the clinical of the patient, it suggests that this is acute case.
Yes, it's an acute case, and we have acute infarction along the left middle cerebral artery.
Okay.
How can we confirm? You are doing very well. Okay, you are going straight forward to the diagnosis. How can we confirm? What should we search for in any stroke patient? Stroke. We don't have any hemorrhagic insult.
The insular sign. Do you mean insular?
We have
the vascular and the blood vessels, the middle cerebral
we should search
artery,
for any acute signs of cerebral infarction. Yeah.
Okay. I couldn't see that. I can see that there is evidence also of ribbon sign and loss of differentiation slightly between.
Okay.
I want also to look for the middle cerebral artery in the blood vessels if there is dense sign.
Yes. Okay. Do we have any dense sign?
Yes, in the left middle cerebral artery.
Yes.
Dense sign. Okay.
Yes. Okay. So we have here M1 segment hyperdense sign, confirming that we have acute
middle
infarction of
cerebral
the
artery
left middle
infarction,
cerebral artery.
thrombosis
Yes.
with
Yes,
infarction.
I would like to add something. Once we have any infarction, we should apply aspects score. Aspect score is Alberta Stroke Program Early CT score. How can we apply this one? Because it is very important of prognostic value. We should add 10 points total. What are these 10 points? The putamen 1. The caudate head is normal, but the caudate body here, it's not normal. So we have 2 points now. The internal capsule almost normal. The insula, we have 3 points. We have 3 points. The insula. So we have 3 points. The internal capsule is free. We have also the lateral to the insula. We don't have any infarction. Anterior to the insula, posterior to the insula, frontal operculum and posterior temporal region. We don't have any affection here, but we have here, this is free, this is affected, and this is affected. So we have here in total 5/10 segments, 50%, 70% or more is characterized by bad prognostic value. If you want to add your aspect score in your reporting, it will be much help. Okay? Thank you so much. Just I would like to, we have, this is non-contrastive scan of the brain. And as you can see here, this is marked hydrocephalic changes, supratentorial. But the most important or the most difficult point that you should check is the dictum of the midbrain. Here, the dictum is bulky, and you should take care of this one. And this is the sagittal T1 weighted tremors, and you can see here the superior colliculus and the inferior colliculus of the dictum is markedly enlarged, and this lesion displays hyperintense signal in the T2 weighted tremors, and it doesn't show any significant post-contrast enhancement. What do you think? Can you help me in diagnosing this case? I would like to read the SHAT tictal plate. I would like to read the SHAT if anyone wants to write the diagnosis for this case. Yeah, tictal plate glioma. Yes, very nice. Okay, this is tictal plate glioma. And I think now we finished almost all the diagnosis and differential diagnosis of the posterior fossa mass lesions in the adult and pediatric age group. Also, we covered some of the most important emergency situations, either post-traumatic or ischemic insult, acute ischemic insult along the anterior circulation or posterior circulation. I hope you enjoyed our session today. I'm sorry that it was a very long and heavy session. I would like to thank all of you. And if you have any more comments, I would like to hear from you. And inshallah, this session will be uploaded to the YouTube channel. Thank you so much, and have a nice day.